And his current position, he oversees the following: tobacco control, prevention program, the nutrition and physical activity program, the cardiovascular and school health program, policies for livable, active communities and environments called the PLACE program, injury and violence prevention program, and Office of Senior Health. So you can just go to him. He's a one-stop shop, and he'll be able to solve all our issues. He also oversees a First 5 LA-funded early childhood obesity prevention project and a CDC-funded community transformation grant addressing obesity, tobacco use, and chronic disease prevention. He's very busy. He also received his MD from the University of Michigan School of Medicine, his MPH from the UCLA School of Public Health, and he's board certified in pediatrics, yay pediatrics, and preventive medicine. He completed a 2-year fellowship in the field epidemiology with the Epidemic Intelligence Service. It's called the EIS program at the Center for Disease and Control and Prevention in 1992. And then he served as the medical epidemiologist in the CDC's division in HIV/AIDS prevention, assigned to the LA County HIV epidemiology program from 92 to 98. 98 to 2006, and he was also the director of the Office of Health Assessment and Epidemiology in the LA County Department of Health. I think Paul followed his gut like Steve Jobs. And so please welcome Dr. Paul Simon.
So my job this morning is to sort of pivot from what's happening inside the body to what happens across the population. That's how we in public health are judged. We look at trend lines, and at the end of the day, are we turning the curve on obesity and other health problems? And I didn't add this slide, but probably should have, but just to give some perspective, if you look at the trend line for tobacco use and you look at youth in Los Angeles County, between 1997 and 2013, the rate of tobacco use among high school kids went from 24.7% down to 6.7%. That's turning the curve. We're very excited about that. And it surely isn't only the health department, it's many, many folks working on this issue, working on it from a population health perspective. But it caused me to reflect a bit. It took 15 years or so to do that. And the rate of tobacco use in 1997, 24.6%, is about where we're at with childhood obesity in Los Angeles County and across the country. And so 15 years from now, we're on to 2030, 2031. Will we be down to 6.7% on childhood obesity prevalence, which is about where we were at pre-epidemic in the 1960s? I wish I could say that I'm confident that we'll be there, but I don't think right now we found that trajectory to get us there. So I actually come to you today with some humility because we have lots of ideas about what we need to do, and I think some pretty good research supporting what needs to be done, but we've not quite found the way to mobilize public support to move in the direction we need to, and also we just don't plain have evidence to be confident about what works yet. But I want to share this morning what we're doing in Los Angeles County. We're the largest local public health jurisdiction in the nation, and I think have some really interesting dynamics here that I'll share with you. So for the medical students and physicians out there, I just want to really highlight the triple aim, which is the bedrock of our healthcare reform efforts. And for the first time, it calls out population health. If we talked about healthcare reform 10 or 15 years ago, it really would have been the first bullet, improving clinical care, the quality of clinical care, and it would have been the third bullet, reducing healthcare costs. But I think there's a growing recognition that we need to do work beyond the walls of the clinic and the hospital, out in communities, if we really want to promote health and achieve our population health goals. So the question today really is, how do we reduce obesity across the population? Is it merely a matter of doing one-on-one services, which are indeed very, very important, or do we need to do more and think at the population and community levels? So I think there's some interesting data that give us some clues. I describe these sorts of trend data as hypothesis generating. They're not by any means hypothesis testing. They don't tell us conclusively what causes may be operating, but they're provocative. And so these are data on the rate of overweight, obesity, and extreme obesity, body mass index above 40, among adults nationally. It's from the National Health and Nutrition Examination Survey. Very, very high quality data. I have a lot of confidence in it. And if you look back in the 1960s all the way through about 1980, you see a very, very slow, I would say very minimal increase. The obesity prevalence, for example, and I'm focusing not on overweight, that top line, which has stayed surprisingly relatively stable, but the middle line, obesity prevalence, body mass index 30 or higher. Between 1960 and 1980, there's something going on. The prevalence went from maybe about 12% to 14%, but something happened around 1980, and between 1980 and on into the first decade of this century, the obesity rate skyrocketed up to over 30%. That is so rare to see something like that, of that magnitude, in relation to a chronic disease or a chronic risk factor. It just begs for some further study to understand what's happening at the population to trigger that sort of dramatic increase. And if you look at extreme obesity, a parallel, much lower, but still very, very disturbing increase. The level of overweight has stayed the same because as people move out of the overweight category into the obese category, there are folks in the normal weight or healthy weight category that are shifting into the overweight category. So you're seeing a shift of the entire distribution to the right over the course of 20 years, 20, 30 years. Similarly, if you look at children across the nation, again, a very representative sample, strong data collection methods, and you see that in the 1960s on into the 1970s, the prevalence of obesity among children, both elementary school age kids and adolescents, was relatively stable in the 6 to 8% range. And then something happened around the late 70s, early 1980s, and we started to see this rapid rise on up to about 15, 16%. It's continued to climb, but more slowly. In the early 2000s, it was up at around 20%, 21%, and now over the last few years, you've maybe read in the news that it seems to be leveling, maybe in some jurisdictions, including Los Angeles, the beginnings of a decline. And so, just to share some Los Angeles County data, where the trend is disturbing, and it continues on through the first decade of this century. If you look at the prevalence of obesity among adults in Los Angeles County, you see that back in 1997 it was 13.6%. These are data from our LA County Health Survey, and I remember I had just begun working in the office in the county that oversees this survey, and as we planned the 1999 survey, and there was so much interest in the survey, people are arguing about what questions to include in the survey. You can't keep people on the phone too long. And I argued, let's take the height and weight questions off because we're not going to see any change in just 2 years. We can put it back on the survey the next time we do it. It'll create space for other questions. I was overruled. We included the height and weight questions, and to my surprise, the data in 1999 showed a significant increase in the prevalence of obesity among adults. Thereafter, we've included those height and weight questions in every survey, and what we see is maybe a slight slowing in the growth in the increase, but nonetheless an increase through 2011. We're now in the field with our 2014 survey, and hopeful that maybe there'll be some leveling, but hard to say till we have the data. And just to put these percentages in perspective, to go from 13.6% to 23.6%, that's equivalent to 750,000 adults in Los Angeles County who are obese today, who would not be if the rate was back down where it was in 1997. That magnitude of change doesn't happen by chance, or doesn't happen because of subtle differences in whatever factors are operative. It really suggests that there's something very dramatic happening in our society. And as I may have mentioned, the parallel increase in type 2 diabetes, well actually diabetes, we don't distinguish type 1 and type 2 in our survey, but presumably mostly type 2 diabetes. So among school-age children in Los Angeles County, these are data from the school system. All 5th, 7th, and 9th graders are required to get height and weight measured each spring, and we've, with some difficulty, been able to get the data from the California Department of Education. Concerns about confidentiality are challenging. But what we saw beginning when the data first began being collected in 1999 and then on through about 2005, a very steady increase in the prevalence of obesity among these school-age kids, peaking at about 23%, almost a percentage point increase per year, which may not sound like much, but that's about 15,000 kids every year who now are obese, who would not have been if the prior year's rate were still in effect. Something seems to have happened since 2005, and we've seen a leveling, at least through 2011, maybe the beginnings of a decline. I've seen now the more recent data, which suggests a continued slight decline, but not as dramatic as we would like. Another important clue, I think, to what may be happening is that it's not just school-age kids and adults, but if you actually look at young children, in this case 3- and 4-year-olds who are participating in a nutrition assistance program called WIC. It serves primarily low-income families, but it's a very significant subset of the LA County's young child population. It reaches between 50 and 60% of all children from birth through age 5. So it's very significant, the trend line. And here again, if as I would present these data several years ago, it was all doom and gloom. It was showing essentially about a percentage point increase every year, with the rate of the prevalence close to 22.5%, not far off from what we see in adults and school-age kids, suggesting that what's happening here is happening very early in the life course. Since about 2009, we've seen leveling, now the beginnings of a decline, which temporarily at least is associated with some very impressive changes in the WIC program, not only some very innovative education interventions, but also efforts to incentivize healthier food purchases among WIC family participants. So another I think very interesting and important epidemiologic finding here in Los Angeles, and probably true in many other jurisdictions, although here it's about as dramatic as what I've seen anywhere else. The disparities geographically across the county. LA County has 88 cities and has a large unincorporated area of about 1 million residents, and because the school data includes so many children, close to 300,000 children each year, we're able to do some pretty local geographic analysis and look at results by city. And within the big city of LA, we can break it out by council district or any other number of boundaries. Within the unincorporated area, there are census-defined communities. And so we've looked at childhood obesity across about 140 geographic units within Los Angeles County. And you don't have to be from Los Angeles County. In other words, it's pretty clear. You don't need the columns there that show rank of economic hardship. What you see on the left are the communities with the lowest childhood obesity rates, the lowest being Manhattan Beach, about 2.8%. The average, about, hard for me to see here, 7.2%. These are among the most affluent cities in the county. If you look on the right, the other extreme, the 10 with the highest rates of childhood obesity, the highest being South El Monte, about 34.1%. The average about almost 31%. So really two completely different worlds here. These are literally thousands of kids that are living under very, very different circumstances. We've actually tried to correlate this variation with a broad number of factors. So, for example, we've looked at it in relation to the density of fast food restaurants. We've looked at it in relation to green space per capita, park space per capita. We've looked at it in relation to crime rates. We've looked at it in relation to demographic factors. Economic hardship, by far, is the strongest correlate of childhood obesity in the county. And so it, again, begs the question, what are those things associated with economic hardship at a community level that would predispose to childhood obesity? And so why are we concerned about childhood obesity. I don't have to spend a lot of time on this, but just to point out that the studies show a pretty strong tracking from childhood to adulthood, unfortunately, in overweight and obesity. And of course, with obesity during adulthood, a whole host of chronic health conditions, very costly from both a human and economic perspective. But we're also seeing very significant adverse health effects during childhood as well. So for example, we're seeing a number of medical complications, things like hypertension, hyperlipidemia, type 2 diabetes, insulin resistance at much higher levels. I was just talking before at the break with a couple colleagues here who shared with me their experience working with kids in the clinic, many of whom are obese, and the very high rates of liver disease, very significant problem, non-alcoholic fatty liver disease, which isn't often talked about, but really has some very serious implications over the next 10, 20 years, where in fact many kids as they progress to adulthood may be developing liver disease that progresses to liver failure and even liver cancer. The epidemic of obesity among adults and increasingly among children is also very costly. In Los Angeles County, 2006 data, a total of close to $6 billion, about a little more than half of that healthcare, and then the other half lost productivity. I think these are very conservative estimates. I would guess that it's probably close to double that right now. And so the question is, why is there an obesity epidemic? And the simple answer everybody points to is that it's a chronic energy imbalance, calories in greater than calories out. I think what you heard from Dr. Mayer, though, is that what happens in the body is, and with energy metabolism, is very, very complex. But it is indeed true that we've measured over time a very significant increase in the population in caloric intake, ranging anywhere from 100 to 250 calories more per day per individual. On the physical activity side, the data isn't quite so clear. In fact, contrary to conventional wisdom, the data suggests that there hasn't been as much of a decline in physical activity as many people think, which is not to say that we're physically active enough. There's way too much sedentariness in the population. But definitely in regards to eating, lifestyles have changed dramatically in how much we eat, in what types of foods we eat. But really, when we think about prevention and trying to turn the curve on the obesity epidemic, we have to kind of peel the onion and get a little bit deeper in and understand and ask the questions, why have lifestyles changed so dramatically in the last 30, 35 years? Is it simply a collective loss of willpower, which is really, when you think about most of the interventions, most of the discussion about how we need to address obesity, it's really almost always, it's rare that I hear that it's not about the individual, and that we have to implore people, encourage people to do more. Has there really been simply a loss of collective willpower over this last 35 years that would explain that dramatic rise in obesity prevalence? Is it a lack of knowledge and awareness? There's no question that we need to increase knowledge and awareness in the population, but has it really changed that dramatically over the last 30 or so years to explain this dramatic rise in the obesity prevalence? Probably not. So I guess one must ask, what about the environment? What's happened over this period of time? And this is a photo from Figueroa Boulevard, very close to the USC campus. I spoke to some USC students about 2 months ago, and they all immediately chuckled when they saw this photo, but it could be really almost anywhere in the United States. It's not that fast food didn't exist in the 1960s. I'm dating myself now, but as a young child, I can remember a McDonald's not far from my house in Michigan. But it wasn't on every street corner. I mean, the sheer density of fast food has grown so dramatically since the 1980s. And it's cheap, it's accessible. As a society, we value convenience, and consumption has grown dramatically. I mean, you all, I think, understand this, but it's also overwhelmingly calorie dense, high fat, high sugar, high salt. If you look at how portions have changed over the last 30 years, there's been dramatic growth, and this slide sort of schematically shows that, not just beverages, but all sorts of foods. If you look at the size of plates that are used today compared to, say, the 1960s, the size of plates are much bigger as well. What we use now for dessert plates were dinner plates in the 1960s. Think about advertising and its impact. Dr. Mayer mentioned that briefly, how it appeals not to the rational side of our Constitution, to our brains, but rather to our emotions. And the industry wouldn't spend billions of dollars on advertising if it didn't work and if it didn't powerfully influence what we buy. And it's not just the traditional television advertising. Think about how marketing has evolved over the last 30 years. Celebrity endorsements, cross-promotion with toys. The fast food industry is now the largest manufacturer of toys for children. The new ways of reaching the population with the internet and now smartphones, viral marketing, all done with growing levels of sophistication, which very clearly, study after study show, influence our behavior. Just one study that I found very interesting, it's sort of a seminal study done over a decade ago by a pediatrician up at Stanford, Thomas Robinson. He and his colleagues took a group of young children, low income, 3 to 5-year-olds, and gave them identical food. One set wrapped in paper with the McDonald's logo on it. The other food wrapped in identical paper but without the McDonald's logo. And the study showed very clearly brand preference for most of the items. Everything except hamburgers were not statistically significant, but everything on there, chicken nuggets, french fries, carrots, milk, apple juice. Children at that young age showed brand preference. Interestingly, the effect was stronger among children who watched more television, not surprisingly, and in the study, about 55% of these young kids had televisions in their bedroom, which has been shown to be another risk factor for obesity. Also, a stronger effect, not surprisingly, among families who serve their children McDonald's more often. A photo of a vending machine in one of our public health centers, not today, but a few years ago. And I think Dr. Mayer may have mentioned this, but the importance of price. And I can assure you that the food beverage industry, and in fact all private industry, thinks very, very carefully about how they price their products. Price is an incredibly powerful influence on what we purchase and consume. And so what is this message here in a public health center where you have the soda for 75 cents and then water $1.25? What I heard just earlier, Dr. Slusser shared with me some work they're doing on campus here with actually placement of healthier products in vending machines at eye level or in places where they're more likely to be seen, and with pricing strategies, pricing more favorably the healthy stuff, less favorably the unhealthy. It's had a very dramatic effect on what people select. We don't often think a lot about what we eat. Believe it or not, we think we do, but we don't. It's been described by some as automatic behavior. We do it almost without thinking. Whatever is on the plate, no matter how much or how little we eat, we aren't particularly sensitive to our internal cues around hunger, but rather these environmental cues. This next photo, I think, highlights something very disturbing about a public program, the food stamp program, or what it's now called the Supplemental Nutrition Assistance Program, SNAP, a very, very large government program. It pays for about $76 billion a year for food for families in need, low-income families. There are very few restrictions, though, on what can be purchased. And so here is an EBT, electronic benefit transfer, is the card that's used to obtain the benefit. And so what you see here is an advertisement for large bottles of soda to be used with food stamp benefits. On the physical activity side, we've sort of engineered physical activity out of our daily lives. We feel the need, if we're going to be physically active, it's got to be part of an exercise regimen. We have to join a health club. Sadly, though, in many of the communities where obesity rates are highest, families don't have the resources or the time to join a health club. And there's growing interest in trying to design our communities in ways that allow us to more easily integrate physical activity into our daily routine the way it was 50 years ago. Share more about that in a moment. Unfortunately, though, when you think about walking and biking, and particularly in a place like Los Angeles, it's just not very safe, not conducive to walking. And in fact, our communities are designed in ways that make it unlikely that we would walk for a purpose. In many other parts of the world, for example, we wouldn't think twice about walking to the store or to run errands. But the way our communities are designed here, with the separation of residential and commercial, we have to rely on the automobile. So I'm looking at my time. Okay, I think I'm okay. I want to talk a little bit about our intervention strategies to date in Los Angeles. But again, let me just point out that we don't have the definitive answers. But I would say our work can be broadly categorized as community education, trying to increase knowledge and awareness, and using some of the same advertising techniques that the industry uses to influence, to try to change attitudes, beliefs, and hopefully in the long term behaviors. We're also doing a lot of work to help improve skills. For example, teaching people how to read nutrition labels, providing recipes for healthy options, and helping them learn cooking skills, which have declined over the last 30 or 40 years. Our biggest focus, though, I think, given the importance of the environment, is on what we call policy, systems, and environmental change. The phrase that's often used is making the healthy choice the easy choice, or even more importantly, making it the default choice. When you think about it, we as a society are obsessed about obesity and what we eat. And in a way, it may sort of be counterproductive. It causes lots of cyclical behavior, lots of angst, and probably adverse mental health effects. If you look at societies where there isn't much obesity, they're not spending much of their time thinking about obesity or thinking about what they eat. It's just natural, because that's their culture, the social norms, and the physical environments all together make it natural that people would eat healthfully and be physically active. That's where we're trying to get to in this nation. We have a very long way to go. We're focusing a lot of our work on children and on prevention, because while there are lots of examples of adults who are overweight or obese who've made miraculous progress, have been able to reverse that, lose weight, and sustain it, it's difficult. And if we want to move the needle on the population level, we feel we have to focus a lot of our efforts on prevention and younger age groups. Because of those geographic disparities I mentioned, we're focusing a lot of our efforts in certain communities. So I'm just going to quickly run through some of our activities, not by no means all, but we are working with healthcare providers, although we hear some frustration from healthcare providers because they feel that the opportunities, that their power to actually change or move the needle on obesity is, their view is sort of one of pessimism and frustration, because they often don't have a lot of success. Although I would say there are some very promising programs with better results, but it requires, I think, a change in the way healthcare is provided. For example, multidisciplinary teams. We are working with healthcare providers, particularly pediatric providers, to get them to better track body mass index, and when they begin to see children that are sort of moving up percentiles, to very early on refer the families in for supportive services. We're working with hospitals to get them designated baby-friendly. We hope all hospitals are baby-friendly, but baby-friendly is a specific WHO designation related to having a facility that's very supportive of breastfeeding. And there are some studies that suggest that breastfeeding can be protective against obesity in later childhood. We're doing a lot of work with child care providers, trying to improve the food served in those settings. Working a lot with school districts on school meals. We've had a lot of success in improving the nutritional quality of school meals, where we're falling off, though, I think, is improving the appeal of school meals. A lot of the food, unfortunately, ends up in the waste basket. We're using a whole school of theory called behavioral economics to try to get students to actually select healthier options. But the way you actually design a cafeteria, how you promote certain items, can have a very powerful effect on what kids select. So for example, simply by putting the white milk in front of the chocolate milk, you don't have to get rid of the chocolate milk, but by putting the white milk in front of the chocolate milk, believe it or not, 10–20% more kids will choose the white milk. They won't bother to reach further in to get the chocolate milk. Lots of examples like that. We feel behavioral economics as a strategy to nudge people to healthier choices is very promising. A lot of work with employers and workplaces. I think the activity at the break was a great example of that, but there are lots of workplace policies that could incentivize physical activity and improved eating. Dr. Slusser mentioned our PLACE program, which works very actively with cities, city planners, transportation planners, trying to create more walkable and bikeable communities. We're focusing a lot on the food environment with a lot of success around farmers markets, expanding both the number of farmers markets and also the ability of farmers markets to accept the EBT benefit so that folks on food stamps can actually purchase fruits and vegetables at farmers markets, and even with some incentive programs in place, get more for their dollar if they purchase fresh produce. We're working with small neighborhood markets. We have a whole network of small market owners who are interested in carrying healthier options, but they need some technical assistance in doing that with refrigeration. We're creating a group purchasing collaborative so that they can obtain the fruits and vegetables more economically, so that they then can sell them at more affordable prices. But at the end of the day, if we really want to turn the curve on obesity, I think the latter two bullets are sort of ground zero. What happens in supermarkets and what happens in restaurants. We do have a new restaurant program called Choose Health LA Restaurants. It's focused, we actually did a lot of focus groups with restaurant owners and decided not to introduce a program that they would all reject. So we weren't able to do everything we wanted to do, but these were the areas where they seemed amenable to working with us. One is to take their existing items on the menu and to offer a certain percentage with lower portion options. Secondly, they seemed very supportive of efforts to improve the nutritional quality of children's meals. So those that actually had children's menu items, they committed to meeting certain nutrition standards for those children's meals. To date, we have we've gotten Subway, very largest chain actually in the world. And you'll see if you go into a Subway, you'll see our Choose Health LA restaurant logo. They were already doing some good things. They've improved the quality of their children's meals a bit. We've gotten about 100 other restaurant sites participating, but it's a real challenge because it's a very competitive industry and restaurant owners are hesitant to want to make changes that are going to put them at an economic disadvantage. The marketplace, though, has power, and one of the reasons we spend a lot of time trying to increase community knowledge and awareness is because consumer demand can actually drive change in the marketplace. We're already seeing it. This was from the LA Times late last year. Bye-bye burgers, new fast food chains bet on healthy eating. There's a growing number of fast food chains. So in other words, they are capitalizing on our society's liking of convenience, but offering what they perceive as a growing want within the community, which is healthier options. Unfortunately, we're seeing most of it still in the more affluent areas, although we are seeing now some dissemination to the more disadvantaged communities, but we want to try to accelerate that. We're doing, as I mentioned, some media campaigns. This one, portion size, was designed to support our restaurant program. We're also very concerned about the unhealthy food and beverage marketing that's targeting young children. Most of the discussion about trying to restrict that has been at the federal level because that's where most of the legal opportunities are to do it. The First Amendment is very powerful, free speech. It's hard to beat that. And so there have been legal cases that have blocked efforts to try to restrict marketing on that free speech argument, along with some other legal arguments. But we've actually retained a state-of-the-art firm in the Bay Area with legal expertise who will share with us a white paper in the next month or two that we will disseminate broadly, which provides recommendations for how local jurisdictions, what sorts of things are legally feasible at a local jurisdictional level to try to reduce food marketing, unhealthy food and beverage marketing to young children. We've done a sugar-sweetened beverage public education campaign that got a lot of traction. You wouldn't eat 22 packs of sugar. Why are you drinking them? Many folks, as we do our education, are shocked to learn how much sugar is in these drinks. On average, we, believe it or not, consume about 68 pounds of sugar each year, and that's grown dramatically over the last 3 decades. We were heartened to see, though, we actually did a pre and post and did see a significant decline in sugary beverage consumption in our population. It mirrors a trend, though, that's been seen more broadly across the nation. The beverage industry, I think, is quite concerned there. The sales of sugary beverages, particularly soda, has gone down very dramatically, not so much on the energy drink side, but we're making progress. We think these data to some degree reflect the effects of our program, because the greatest drop we saw actually was in the Spanish-speaking Latino population, and that was a subpopulation that we targeted very intensively in our campaign. There's really some interesting discussion going on about other policy strategies, and I clipped this one from JAMA, which is generally a pretty conservative publication, isn't real forward-thinking necessarily always about policy, and this was very provocative. The real cost of food: can taxes and subsidies improve public health? So the argument they're making, it's a 2-pager, I would urge you to look it up, it's an easy read, but they're arguing that just taxation alone is not politically palatable at this point, but if you combine it with subsidies, a more balanced approach, I think it's still politically very challenging, but over time there may be more possibility of instituting something like this, where you subsidize the healthier options and at the same time tax the less healthy, and create overall sort of a budget neutral plan. The challenge really is, I know as a government worker, that the public really frowns upon too much government interaction. And this is Mayor Bloomberg cast as the nanny when New York City and he and his health department proposed a portion cap on sugary drinks in New York City. And it was overturned in the courts, but it really was also, I think, greatly frowned upon in the court of public opinion, even among left-leaning comedians. I think Mayor Bloomberg was the butt of jokes, and it really was, I think, an illustration of how far we have to go to get the general public and policymakers to understand that we do need to manipulate things in the environment if we have any hope of reversing the obesity epidemic. I would say, though, that despite the fact that the policy proposal was defeated, it had, I think, a major public health benefit. It greatly increased public awareness about the potential harms of sugary beverages, which I think was one of the goals. So just some closing thoughts. The first bullet, I think, is probably the most important point I want everyone to take home, which is that currently we think about obesity in the context of the individual, and almost everything we're doing is in the context of the individual. But if we hope to reverse the obesity epidemic, we have to think collectively at the population and community level. We need to focus a lot on prevention. We can't forget about people who are already obese, who are trying to lose weight, a very important population. In fact, even with physical activity and little success in reducing weight, but more physical activity, you can get tremendous health benefits. But if we want to move the needle on the epidemic, we have to focus a lot of our efforts on prevention. We have to intervene early in the life course. Even there's good data showing intergenerational effects. So important to think of we're working on campaigns that are called preconception health, trying to help women in childbearing age become healthier for themselves, but also because there are implications for their offspring if they choose to have children. And then the environmental changes that I talked about. We're not quite sure yet what works, but we have to move in that direction. We have to build public support for environmental interventions. Clearly, that's not going to happen without multi-sector engagement, including the food industry. This may be somewhat controversial, but I'm not very confident that we're going to be able to do it without government regulation. If you look at every public health success over the last 100 years, it's come with some level of regulation, and I just don't see us turning the curve without that on the obesity side. And then I think it's going to require perseverance. I'm not confident we're going to do it in the next 10 years. It's probably going to be 20, 30, 40 years. I'll close there, and these are our websites with more information about our programs. Thank you.